Okay, so let's discuss Chapter 42, Part 1, The Child with Cardiac Disorders. Okay, you need to make sure that you familiarize yourself with the normal heart and blood flow. Blood flows through the inferior vena cava, and it goes into the right atrium, to the right ventricle, to the pulmonary artery, to the lungs, to the pulmonary veins, to the left atrium, to the left ventricle, to the aorta, and out to the body. So, we're going to talk about some common signs and symptoms of CHD. There is failure to thrive, poor weight gain, cyanosis, pallor, tachypnea, dyspnea, irregular heart rate, rhythm, clubbing of fingers, fatigue during feeding or activity. If a newborn has feeding problems initially and then tires easily during feedings, then you need to really think cardiac. They may have excessive perspiration, especially on the forehead, and or fluid retention. So continuing with congenital heart disease facts, it occurs in about 5 to 8 out of every 1,000 live births in the U.S. each year. This accounts for approximately 40,000 per year or 1% of live births every year. 50% or more of children with a congenital heart defect have symptoms within the first year of life. However, defects such as mitral valve prolapse may not become obvious until later in life. Congenital heart defect is a principal cause of death in the first year of life after prematurity. Congenital heart defect is often associated with other genetic anomalies such as trisomies 21, 13, and 18. Okay, for diagnosis, it's usually done by clinical symptoms. Diagnostic testing helps to diagnose congenital heart defects. A critical CHD test on neonates now mandated in the state of Missouri prior to discharge from newborn nursery. And then pulse oximetry testing is conducted on the right hand for 1 full minute, with the result being recorded. Then testing is conducted on either the foot to determine the absolute difference in the results. You want to see critical CHD screening toolkit that contains the algorithm to follow. Then we have the electrocardiogram, ECG. Be sure to change electrodes every 1 to 2 days due to risk of skin irritation. Remember, white on right, green on the ground. Sometimes red replaces green, so smoke white and black above the fire, which is red, and then black on the left. Remember to treat the patient, not the monitor. Prior to administering rate and rhythm altering drugs, remember to auscultate to ensure that the monitor is correct. Then we have the echocardiography, one of the most frequently used tests for diagnosing congenital heart disease. It allows for a confirmed diagnosis without a cardiac cath. Although it is non-invasive, it can still be stressful for the child and parent, as the child must be still and quiet. Moving, changing positions, and crying often results in testing errors. Then there's the cardiac catheterization. It's invasive, usually inserted percutaneously. Types of cardiac caths include diagnostic. It's used to diagnose defects, particularly in symptomatic infants, also used prior to surgical repair. Then there's interventional catheterization. It's used for the treatment of congenital heart disease in certain instances, such as dilating stenotic valves or closing abnormal openings, such as a ventricle septal defect. Then there's electrophysiology studies. This casts with electrodes that record impulses directly from the heart's conduction system, and they're used to evaluate dysrhythmias. Procedural or pre-procedural care includes a complete nursing assessment, preparing the child and the parents for the procedure, IV insertion and monitoring or administering IV sedation. Post-procedural care is vital signs, especially important to monitor the pulses below the cath site. Distal pulses may be weaker initially but should gradually increase in strength. Also monitor temperature and color of the affected extremity to assess circulation. Take vital signs as frequently as every 15 minutes. You want to count the apical pulse for 1 full minute. Do not rely on the monitors. Dressings, you want to assess for bleeding or hematoma formation. Fluid intake, ensure adequate fluid intake. Blood glucose levels monitor for hypoglycemia. Children and infants should typically receive D5 or D10. And then you want to look at and see your nursing alert, family-centered care in the critical thinking case study on pages 1320 through 1321 of your textbook. So continuing with diagnosis, the top left is a chest x-ray of a child with tetralogy of Fallot. The middle x-ray is a normal echocardiogram, and then the upper right is an MRI of a child with a congenital heart defect. Can you guess which one? Take a hint. Look at all the chambers. So, common treatment is usually surgery for most defects. During surgery, the child will typically have a thoracotomy. It's placed on cardiopulmonary bypass, and hypothermia is induced to decrease blood loss and enhance the child's response. And then we have the transplant. This is a treatment of choice in certain cases of congenital heart defect, such as the three-chambered heart, hypoplastic left heart. Okay, so let's kind of review the classification of congenital heart defects. Categories. We have cyanotic and acyanotic. Traditional ways of classifying defects, however, it can be problematic as children with acyanotic defects may eventually develop cyanosis. Classification system. Physiological categories in which the defects are organized based on blood flow. We have increased pulmonary blood flow, decreased pulmonary blood flow, obstructed or restricted blood flow out of the heart, and then mixed blood flow. Figure 42-3 on page 1324 outlines the classification system. This ends part one of cardiac dysfunction.